Hello, welcome, good morning, good afternoon, and good evening to everyone joining us for this satellite session of the 2021 CUGH virtual meeting, Utilizing Technology to Expand Capacity for Health Education. This event is co-sponsored by the Consortium of Universities for Global Health and Seed Global Health, and I am your host for today's satellite. My name is Esther Johnston, and I'm a clinical and academic advisor with Seed Global Health, a family physician, and a faculty member with the Wright Center National Family Medicine Residency Program at Health Point in Seattle, Washington, USA. Joining me as moderators and panelists today are 12 speakers representing Uganda, Malawi, Zambia, and Kenya, each with unique knowledge and a unique lens on the challenges and benefits of integrating new technology into educational programs. We are so pleased to welcome all of you as well. We have in attendance today close to several hundred participants from across the globe: nurses, physicians, educators, learners, program managers, and directors, and many, many others. We look forward to interacting with you and benefiting from your thoughts, your reflections, and your questions throughout the session. We are gathering today roughly 15 months into the COVID-19 pandemic, at a time when incredible disruption has occurred in almost every aspect of our lives. The impact on education has been profound. The World Bank has noted that at the peak of school closures in April 2020, 94% of students, or 1.6 billion children, were out of school worldwide. And still around 700 million students are studying from home today. At its peak, 220 million tertiary education students were impacted by closures of campuses globally. And according to one study that was done by the International Labor Organization, UNESCO, and the World Bank, 90% of respondents reported a complete closure of technical and vocational education and training centers in their countries. In physician and nursing and other clinical education fields, the challenges are exacerbated by the risk posed to students of being on bustling hospital wards and clinics in the midst of a pandemic, often with shortages of personal protective equipment, and the limitations on being able to continue practical skills training due to the need for physical distancing. As we know, these impacts have highlighted and exacerbated existing inequities in faculty and healthcare worker shortages and differential access to bandwidth, electricity, and training materials. But we are here today because COVID has revealed opportunities alongside the challenges and pushed us to think creatively about how we teach and train future healthcare providers, no matter what the barriers. In the process of responding to this pandemic, we have discovered that some technological tools to enhance and expand the reach of educators are not as out of reach as we thought. And so I'm thrilled that you will have the opportunity to hear today from experts representing academic institutions and nonprofit organizations who were already pushing the barriers to utilizing technology for training before the pandemic began, and who will be able to share their experiences and insights to doing so even after the pandemic ends. Our satellite today will consist of 4 discrete sessions. In each session, we will introduce you to a unique panel of speakers who will share with you their insights and experiences with different aspects of educational technology. In order to minimize disruption from potential lapses in connectivity, the majority of these sessions have been pre-recorded, but during 2 of the sessions, the first and third, we will have time for live Q&A between the audience and the panelists. And during all of the sessions, panelists and moderators will be available to engage with you and answer your questions in the chat and engage in discussion through the chat box. Attendees will remain muted throughout this session due to the size of the audience. But as I said, we really want to encourage that conversation and networking. And you can do that not just through the chat box, but also by extending and expanding the conversation to Twitter. So we have 2 hashtags for you to use today for those of you that are on Twitter or Twitter savvy. CUGH Digital Ed is the hashtag for this session specifically, and hashtag CUGH 2021 is the hashtag for the entire conference. I've also listed some of our Twitter handles here. We welcome you to reach out to us directly or to tag us as you think and reflect on what is shared here today. So with that, I'm going to go ahead and transition into our first session, which is e-classroom and online learning technologies in physician and nursing education. Our moderator is Ms. Margaret Fury and panelists Mr. Leonard Wamakote and Dr. Thomas Baliza-Cuba. So if you'll allow me one moment.
My name is Margaret Fury, and I'm the Nursing and Midwifery Advisor for CUGH Global Health Malawi. I'm here as a moderator for the session on utilizing technology to expand capacity for health education. And specifically, this session will share with you on e-classroom online learning technology in physician and nursing education. We have two esteemed experts who will share with us their lived experiences on the above topic, and the presentations institutionalize open distance e-learning as a viable mode of educational delivery in the context of limited connectivity, other ICT infrastructure, and coupled with strongly held negative attitudes about open distance e-learning among the various stakeholders. We lectures to both undergrads and graduate students in various aspects of ICT application, including ICT in health. And our second presenter will be Thomas J. Baliza-Cuba, a Makerere University trained medical doctor, and fresh came from school and currently taking a mandatory one-year internship at one of the regional referral hospitals in Uganda. We're going to hear from Jerry, his experience as a user of technology. After our presentation, we'll give the floor the opportunity for questions.
Thank you very much, Margaret, and I salute all the participants in this conference. Thank you for attending. We would like to discuss e-classroom and online learning technologies in the education of physicians and nurses. Before we do that, let's get a quick understanding of what we call technology-enhanced learning. The human brain is a very complex structure that up to now, you might wonder, computers, artificial intelligence, and everything have been made, but I don't think we have even reached 10% of the complexity of the human brain. We will probably be around 5%. Now, when you use technology, in this case like computers, to help expand the abilities of the human brain, then we call that technology-enhanced learning. I'll give one quick example. There could be one procedure which takes a very short time that our human brain may not quickly follow and understand. But when this is played out a bit more slowly, then it is understood and it's easier to tell the process. So there you'll have used technology to play the procedure slowly to enhance learning. But technology also enhances learning in that it makes it available for people who are, for example, at a distance. However, as we get to technology, we need to be careful not to fade with the fad. Technology is a fad. Every single time there's a new fad coming. This is a good smartphone. This is something like that. This is, no, every time there's something new. And if we simply want to go with the fad, like all fads, it fades. Tomorrow there will be another. So we can't afford education being taken as a fad. And therefore it's very important that we choose pedagogy carefully, then just use technology to support that pedagogy. And as we do that, we should take care to see whether we are using technology or whether we are learning about technology or from it or with it. Learning about it, for example, if someone tells you how telemedicine operates, you're learning about that technology. But learning from it is when there's a device that transmits what you are going to learn. Now, all of those are not very advanced forms of learning. The most important is to be able to learn with the technology, where the technology, you learn with it, the technology enables you to learn. The bottom line is we need a learner-centric technology-enhanced learning, meaning the learner must be put at the center. The number of modes and examples of online learning now coming down specifically to online learning, which means learning by hooking on to the internet. That's online learning. We need to distinguish that there is synchronous learning. For example, a video conference or a Zoom call like now. Now that takes place at the real time. Everyone must be present at that very time. That's why it's called synchronous. The opposite of it is asynchronous. Like you can post a discussion somewhere online and people will keep discussing. That's asynchronous learning. You can get up anytime. If you are the type who studies better at night, you are free or in a different place. It's quite much more flexible. Now, a learning management system, abbreviated as LMS, is very important in coordinating all these types of learning because it gives it structure and it also moderates the learning. If everybody did what they wanted to do at the time they want to do it without any.
Here we go.
Takes place at the real time, everyone must be present at that very time. That's why it's called synchronous. The opposite of it is asynchronous. Like you can post a discussion somewhere online and people will keep discussing. That's asynchronous learning. You can get up anytime. If you are the type who studies better at night, you are free or in a different place. It's quite much more flexible. Now, a learning management system, abbreviated as LMS, is very important in coordinating all these types of learning because it gives it structure and it also moderates the learning. If everybody did what they wanted to do at the time they want to do it without any coordination, there would be a lot of confusion. So the learning management system is important. Therefore, it's important that you choose a good system that is able to coordinate within your own context and meet your requirements in coordinating that learning. We are also presently very much involved in what is called the flipped classroom model, especially for students learning at a distance. So that instead of what we are used to, the teacher preparing, coming to present the material to the learner, then the learner takes notes and is given further assignments. We begin by giving assignments to the learner, they go and research about the topic, and then they come back to the classroom and present about it. That's called the flipped classroom model, which is a lot more learner-centered than being content-centered as many of us are used to. We also need to understand the term blended learning because it's a very useful one in our context, where some of the courses or the activities are performed online, but others are performed face-to-face. It's much more common in the health sciences, actually most of the sciences. It's very important that some things will need to be done face-to-face. You can't do everything online. So the blend of the two brings us to blended learning. The number of challenges in the online classroom, some of them are inherent to the design of online learning. For example, there are negative attitudes of learners, teachers, and other stakeholders like employers and so on, who think that you just can't learn online. A colleague of mine asked me, if you were given a doctor to work on you, surgery who had learned surgery online, how comfortable would you be? That is a very big question. I probably wouldn't be very comfortable, which is an attitude issue. But there's also.
All right, thank you all so much. I apologize. I apologize for our snafu there. We'll be restarting now.
comfortable, which is an attitude issue. But there's also the usability and the steep learning curve of the technology we use for online learning. Many of our students are struggling, even our lecturers are struggling to just get to grasp the technology. There is the issue of social touch being very minimal, in some cases lacking. We are social beings and we learn best in social environments. If the learning management system does not properly replicate the social environment, you find that you get minimal learning taking place. There's also the issue of integrity and authenticity. If, for example, you are conducting an examination online, how can you be sure that the person answering the exam is the same one who is going to be certified and not another person assisting them, for example? Those are inherent. But there are bigger contextual challenges. For example, connectivity is a big one, especially in the developing countries. We have a lot of connectivity issues. You, first of all, need to be in an area where there is an internet connection. But when you get an internet connection, you need a device that can hook up. And when you have that device, you still need electricity to power it, and it's not guaranteed. When you have the electricity, then sometimes you can't afford the data bundles to be able to connect. And when you are connected, you still may not be able to get on because there's something wrong with the technology at one stage or another. So there's a connectivity problem, there's a problem of access and inclusivity. How do we get devices that can be used by everybody, including people with disabilities, people who are so poor, for example, and the problem of policy development and implementation to make sure that things are following specific policy. So I wanted to let you know a little bit of what we have done at Sitama University, which is a rural university, a university based in eastern Uganda, in the rural area. What we have done, given the situation we are in, to try to cope with this situation. In terms of pedagogy, we have tried to use expert training, and the experts have come up with templates which give us step-by-step procedures to make sure that we follow good pedagogy. And in this, we are thankful to CID Global Health for supporting this training, because the experts were not very cheap to get. There aren't many in the country. The technology, we have opted for the use of open source technologies like Moodle, but we realize that there is one catch. When you go open source, then you need staff who are very well trained to manage the administration of that software. And the catch to we are not very much there. So in some cases, we've had to look for proprietary software. For example, we are now trying out a software called iSpring for developing content. It is paid for, but it makes the work much, much easier than if we had gone using the open source software. So we are trying to straddle between the two, open source and a bit of proprietary. In terms of integrity and authenticity, we have our National Council for Higher Education, which does accreditation, and they came and we took them through the process of what we do before they cleared us to teach online. So we are relying on their accreditation to show everybody that our integrity is good and we're authentic. We're emphasizing blended learning approach because, like I said before, in the sciences, that is what works best. And asynchronous, we're encouraging our lecturers to be as asynchronous as possible to allow flexibility for learners. There's also the issue of connectivity and access is still a nationwide problem. We can't sort it out as a university. It's still a big, big problem nationwide, and the government of Uganda is definitely trying to look at that. But in the meantime, we have tried to give zero-rated access to some of the learners using the networks such that they're able to access our learning management system without paying for any data bundles. But how sustainable this is a problem, because you must pay money in advance to the communication companies. Now, in terms of policy, yes, we had our policy in place, but when you come to implementation, you get constraints because the finances keep changing and they're not available as we wish to have. So the policy is constrained in implementation. What are the next steps? Online learning is here to stay. Colleagues, we cannot hide away from it. We only have to embrace it and improve it. We need to ensure continued user training, very important for users to embrace this technology. We need to strengthen policy implementation structures, because that's the only way we be sure the policy is implemented well. Online learning requires very close monitoring and quality assurance, because things can go wrong very easily. People can post e-books and say, I have finished my course, when actually they haven't done anything much. So very close monitoring and quality assurance is needed. Regular user and stakeholder satisfaction surveys, those are important to give us feedback on what we are not doing very well so that we can improve. We are considering a loan scheme of affordable preloaded devices for some of our learners, so that they're able to connect instantly and they pay back over a period of time. That way it may be more affordable to get the devices. And we also need to consider the use of recognized qualification badges. This is critical, colleagues, especially in the health professionals. If you take a nurse, for example, after a nurse has gone through a certain process, and we know that the nurse understands that procedure, there should be a badge which is given online, and this person is immediately able to be used somewhere in a real world situation according to the badges they have accumulated. So they study as they apply what they have studied. It makes learning more purposeful and therefore increases the motivation. I want to thank you very much for listening to me. But before I step off, I want to welcome my colleague, Mr. Jerry Thomas, who has been introduced to you. Jerry is going to continue this by giving you a real life experience of what he has gone through as they tried to teach a very quick program online. Jerry, you're most welcome.
Thank you very much, Leonard, and thank you, Margaret. And I would like to thank CUGH Global for putting this together, and CUGH for giving us a platform to share this. I'm Dr. Thomas Balizakiwa. Jerry is my branch name. Yes. So I'm going to share in relation to what my colleague has shared, and that is my presentation outline. I'll talk about the background of what we developed and the process of how we came up with a platform. It's called Infection Prevention and Control, that is IPC up there, online training class, and it was for COVID-19 in Uganda. So the background, why did we come up with this? So the COVID-19 pandemic, nationally and internationally, affected very many programs. The economy, affected health, affected education. And in this context, it is the education programs where in Uganda here, all schools were closed. That was around March 20th, 2020. And this was a preemptive measure to avoid the spread of COVID-19 in these institutions, because we find that they house over 15 million Ugandans, and these are crowded institutions. So if COVID-19 landed there, it would have been disaster. So this was done as a preemptive measure to prevent the spread of COVID-19. But as the pandemic went on, there was need to reopen schools. And this reopening, the imminent need was in the health sector, where frontline health workers were needed. And these frontline health workers, they come as the fresh graduates from schools. For example, the level at which I am, I'm part of the people who have just finished school, and now we are offering frontline health services. So there was that need to reopen schools, and priority was given to these finalists. So it was really necessary to equip these people as they were traveling from their places to the institution, because they were awarded the privilege, since they are few, to use the whole institution. So there was a possibility of social distancing and also effecting the SOPs. So they were allowed to come back and train, to have in-person training, combined with online classes. So it was necessary to equip these people with the necessary knowledge and skills, even from where they're traveling from, to take the precautions to prevent themselves against COVID-19. And so from that way, and even the institution to continue with the same knowledge. So in that way, we came up with a student-led initiative to scale up this access to the knowledge and skills of preventing COVID-19. And that is the reason why we got that platform designed. So how did we do this? This was done as a multi-stakeholder engagement. We had representation from government, that is the Ministry of Health. The materials were adapted from the Ministry of Health materials that they used to train health workers, knowing that most of these people who are coming back were health workers. The materials were adopted were close to there because they were going to work in hospitals, because final year is more hands-on. So we adopted materials from the ministry, we had guidance from the ministry, we had regulatory bodies. For example, the National Council for Education that my colleague has talked about. Yes, these materials were approved and they fit very well within their standard operating procedures, what they specified, and some of them, the modules are offered by representation from National Council, which is a regulatory body. We had people from academia, people from civil society organizations. For example, Infectious Disease Institute, they also do part the development of the materials. And then the facilitation work and coordinating all these activities was done by CIT Global, and that is a big plus for them because they were able to put this and it was running. So the platform we chose was Google Classroom. Why did we choose this? It's because it was free. Being something that is starting online classes, they have been there, but their use in Uganda has not been so much. So we decided to use a free program, a free software, a free source that can be accessed by people, because everyone has, most of them have email addresses. So we have a Gmail account, you can easily access Google Classroom, and it's asynchronous. So you can go and access the classes anytime, because these were tough times. Putting together something that is live was not something easy. So we went for, that was the good thing with Google Classroom, people would access the modules that were put there. And it's also not complicated, you can easily be accessed, and manipulation in terms of filling any quizzes, and also accessing the modules is easy on Google Classroom. But the limitations it has is that it is not live. So when it is not live, it poses challenges that, yes, you will see that this person went through this module, but you're not sure that they went through the module. So that was the downside, and it has limited interactions. There is a touch that you get and some special attention when you're doing a live session. You're able to see that this one is not paying attention. For example, if you're using Zoom, they can put up all the questions and you have to answer. Yeah, so that was not done with a Google Classroom. It wasn't possible. And also quality assurance. As I was tracking how some students were performing, how they were going through sessions, you find that you're able to see that someone has just enrolled for the program, but they have skipped the session. And all of a sudden, you see them towards the end. So you have to find ways of alerting them and tracking that. So that was not a good thing with Google Classroom. So we chose Google Classroom, as I've said. And so what we did is we did a recorded voice over PowerPoint, and this was done through Zoom. So we recorded sessions, and these were done by highly skilled people. These are people who have been up on the front line for COVID-19, and most of them are in the Ministry of Health, and they have been at the forefront. So they came together. We got them. For example, we had the head of the COVID clinical case management. So he gave a session, and they were able to put up those sessions together with the PowerPoints and uploaded them. Mobilization of these students was done through an online flyer that was distributed to the WhatsApp groups. So WhatsApp groups are an easier way to locate these people. So that also shows you the challenge in also reaching out to them. And also we used emails. Emails were sent from a higher institution that sent them to the institutional heads to cast them to the heads of the institutions. So the target was the finalists of the professional students, because these were the ones that were prioritized to return to finish their classes and then to go and offer services. And this, it wasn't a standalone. The practicals were to we offered videos there about the practicals. For example, how to mix this, how to put on gloves, how to do for PPE, and the demonstrations were done in collaboration with the institutions. So I'll go ahead and look at what we were able to achieve as this program. So over 200 finalists were trained, and these were trained with got good feedback. People were really having this conception about COVID, and most of them got great more information about COVID. So we achieved that. Over 200 finalists were trained, and time and resources were saved for the institutions and for the students. Since we had limited time the institutions had limited time to finish, the time was saved for them, and also resources of engaging the students, because we offered the theory part and people saw the practicals. So when they went back, they just did the practicals. So that saved time and resources. So the platform also was used for sharing experiences. People shared what they had experienced in the lockdown. People were expressing themselves, and that is good for the platform where social interactions are limited. So sharing what people are going through is really important. And so, and also now leveraging on the online technology in combination with this, finalists have been able to complete their classes. And now they are frontline health workers. For example, personally, we've used online classes in combination with practicals, and we've been able to complete school. And these platforms have also available materials for future reference. Someone can go in at any time and download what you posted, which is at times not so much available if there's a presentation made. At times, some people don't want to share these materials, but on online platform, materials are available and people can share them and access them for further reference. And these technologies have provided low-cost safe alternatives. For example, in Uganda here, we have traffic so much. So imagine if every morning you wake up to traffic, you spend a lot of time and a lot of money. For example, if you use an Uber, you find that you use a lot of money. So if the station can be given online, people will save a lot of money. And these are safe alternatives that do not come together and doesn't increase your chances of getting COVID. So this is or even other conditions. So online technologies are really safe, and they provide low-cost alternatives that should be embraced. So what are the lessons that we learned from this, and how are we going to move forward? So these lessons are more or less the same as what my colleague has talked about. For example, the platform we used was offering passive learning. And passive learning is where, yes, people come in and watch videos and you don't know if they understood. But if you have a platform where people interact, people will really express themselves. Personally, I've attended those classes and I've seen that people, because I've tested both classes, in-person classes and online, people come on the chats and they express themselves. You see that someone was quiet then in class, but here they're freely expressing themselves. They're able to ask questions. So that is a good chance for people to continue learning. So having a platform that allows interactive learning, it will be a nice thing. So the complexities involved, for example, some sites are hard to maneuver. For example, some people would report were not able to access this, but just because they've not maneuvered the system very well. So training of this on how to utilize some of these technologies are important. That as we move forward, as we incorporate the technology, people should be trained on how to utilize them. Leonard has talked about the gadgets we use. So the gadgets are really important, that people don't have enough gadgets, or if the gadgets are used, some of them are inferior, they're not designed to handle online classes. So low-cost devices or even loans, like my colleague has suggested, should be provided. Internet access is a national problem. So we need to find ways of getting subsidized internet packages or even a free platform where students can interact, saving a lot of money. And some of these sites have outdated information. So continuous updating and maintenance of these sites and also the platforms will help us move forward very well. And then also there are inferior test administration technologies. For example, my personal experience is that tests that were administered, they used inferior technologies. So you find that a student, yes, an exam is not bad, but when a student is given a chance to come here, they will misuse the chance. So we need also to find ways of getting supported to tailor technologies to institutions, and we are able to do things the right way, to be assessed in a right way. Also, frequent power shortages. So power is a challenge, and so having devices that can take long on battery, as they can take you the whole day, when power comes back, you charge, that can be good. We also have people who, if you use a passive platform or something that's synchronous, people will not complete their program. So it is really important to use a platform that is live, and people will be able to complete on time. And maybe also moving forward, the other point is we need to be, as a nation, supported to embrace telemedicine for practicals, because this can go hand in hand with the online classes, and in situations where someone cannot do physical classes or even physical medicine, they can rely on telemedicine to get those skills and see patients, see how someone has presented, and that will help them in the future. Also now, for example, like the platform we use, we need scaling up, because, for example, we have the non-finalists who are resuming and they need similar knowledge. So support on how to scale up this will be very, very important. Thank you very much. And yeah, that is the end of my presentation. I want to thank you for listening, and together we can support different nations to bring up online technology, because it has been tested and it is very useful. Back to you, Margaret.
Thank you so much indeed, Leonard and Thomas, for your very informative presentations. I'm sure we have learned a lot from this presentation, and we would be happy to ask you some questions, and we'll open the floor for questions. Unfortunately, we don't have that much time, but definitely for about 5 minutes, let's hear from you on issues that you think require clarification. You can also jot down your questions on the screen, and then we can attend to them. We may not finish them today, but any time. But thank you, and thank you very much indeed. And we look forward to interacting some more, and then even plan to go to Uganda to learn from the experiences that they have shared with us. Thank you very much, and good afternoon.
Thank you so much, Ms. Fury, and our speakers, Mr. Wamakote and Dr. Balizakiwa. We do have just a few moments for chat, and it should be open again. So if anyone has questions for our speakers and wants to put them in the chat, please feel free. And if there are no questions right at the moment, then I'll just encourage everyone to continue kind of reflecting on your questions, sharing them through Twitter. Oh, and actually, sorry, we do have one question. So I will ask our speakers to unmute, and give me just a second here. The question for our speakers, first one is, how is mobile LMS adaptation being used?
To be here. I'm pleased to be joined by two great educators, Miss Christine Abeja, whom I'll introduce shortly, and Dr. Data Santorino, whom I'll also introduce shortly. Today we shall be talking about the impact of simulation in health professional education. Dr. Data is the country manager of CUGH. He is a pediatrician and lecturer at Inferior University of Science and Technology, and a master trainer of pediatrics programs. He is an international trainer of health, Helping Babies Breathe program since 2010, and he has been a trainer in Ethiopia, Addis Ababa, Dhaka, Bangladesh, and right now Dr. Data Santorino leads the Simulation for Life program. So thank you, Dr. Data, for joining us. So we are also joined by Miss Christine Abeja, who holds a degree in bachelor's degree in nursing and a master's degree in care. She's a lecturer at Lira University and works in the emergency unit and intensive care unit at Lira University Teaching Hospital. She has 15 years of clinical experience and 4 years as a faculty member. Christine has received simulation training in helping babies breathe and helping mothers survive. And in order to strengthen simulation at Lira University, Christine has received additional training as a trainer at Inferior University of Science and Technology. So, Ms. Christine and Dr. Data, you're very welcome to this session. So, to start us off, can you share with us what prompted you to join or to start simulation training? Dr. Data, we can start with you.
So thank you so much. I've been, before I became a faculty member of Mbarara University, I studied at Mbarara University. And during my studies, I realized that we made quite a number of mistakes that our faculty at that time were able to stop. But those mistakes were made on real patients. We're lucky that in my experience, nobody died. But then I realized that this method of coming from the class to the ward makes learning a little bit precarious. Some of the mistakes I made, and I was rebuked on the ward, could have been great opportunities not for rebuking, but for learning in a safe environment. And so when I was exposed to simulation methodologies of teaching at University of Calgary, I was very passionate to find a way to start simulation methodology of teaching in Mbarara University of Science and Technology, where we did not have that methodology.
Dr. Data, I'm glad that you're trying to make a difference based on your experience. Ms. Christine, what enticed you or prompted you to start simulation training?
Thank you so much. I first heard about simulation when I joined Mbarara University of Science and Technology in 2017-2018 academic year. Honestly, I was hearing of the word simulation for the first time, and I got interested. I remember asking one of educators in the simulation center, what does the word simulation mean? What is it about? So she tried explaining to me when I actually just got her in the corridor. So in 2018 specifically, we were introduced as master's students to the simulation center, and we ran the first scenario. When we went back to class, I had a lot of questions to my colleagues to answer. Then the second time, the thing became interesting. We took it over. We would time and again, they would take us there to learn some session about the management of patients in the ICU. Personally, I took
keen interest in simulation. It was so interesting. So when Mara University advertised in 2019, they want to train us, helping babies and helping mothers survive, I applied and I underwent the training. It was all interesting. When I came back home in Lira, I was called one day and said, we've sent your name to Mbarara. You were supposed to go for training to be a TOD for the faculty in simulation. I took it upon myself. I went and joined the team for that training. It's all amazing and interesting. I think I just love it as one methodology of teaching students and learners. Thank you so much. Thank you, Christine. So, Dr. Data, can you share with us, I know you touched a little bit earlier, can you share with us a story of when you realized that it's important to have that safe space where students learn before they go straight into touching patients? So just one impactful story that touched you.
As I told you before, my personal experience with simulation for the first time was at University of Calgary. And that was when my aha moment really happened. I was put in a simulation scenario. We did our best on the patient, but we did mess up. And our simulation facilitator used that as an opportunity to teach us. And the approach of teaching was this reflective learning. We were reflecting on our own performance, on our own actions. And I realized that with reflective learning, I was generating questions that I wanted to answer. I was very engaged in my own learning. And that made me think of the many mistakes that we made. I'll tell you a story. When we were in the third year of medical school, one of the intern doctors told one of us to insert a nasogastric tube, and we didn't know how. So the intern doctor inserted the nasogastric tube, but told us, one of us, to listen to the abdomen over the stomach to see whether the tube was in the stomach. Now, my colleague listened when the intern doctor pumped in air into the stomach and said, I think I heard. And everybody took him for his word, though he doubted. And the end result was not very good. That tube was not in the stomach. But if that was in a simulation scenario, we would have discussed and talked about it, and we will have verified it. And our confidence of verifying the correct positioning of NG tubes will have significantly improved, and going to the word will have been confident and not doubting at the detriment of. The other story I would like to share with you was that when we started the simulation in Uganda University, our first target group were very senior doctors. So one time we had a simulation scenario for postpartum hemorrhage. And we put this consultant gynecologist and it was a multidisciplinary team of senior doctors. And we read the scenario. One significant thing was that the patients did not stop bleeding until the scenario was over. And the reason was, this was a scenario of postpartum hemorrhage due to atonic uterus, which the uterus was not contracting because the bladder was full, and they missed it. And during the debriefing, this consultant gynecologist told us, look, this thing looked so real. I was sweating, and you can see at the end of it all, I missed to empty the blood. I will never forget this again. I thought, okay, this is the kind of learning that we all want. And I think these two examples just consolidated my resolve to try and work with partnership with whoever is willing, including interested parties like Christine Laveja and others in different universities in Africa, to try to see how we can hold our hands together and introduce simulation-based learning so that we expose our students and we expose our faculty to reflective learning, consolidated learning.
Wow. Thank you so much, Dr. Data. Those are very powerful stories. Yes, so Ms. Christine, can you share with us one powerful story where you realize that this kind of training is very important?
Okay, thanks so much. As I've said earlier on, that I started involving myself in simulation when I was a student at Mass. Our second simulation scenario, they brought the patient in the ICU, and this particular time they were looking for skills of suctioning a patient. And we were combined with a second year student that was in first year. So the second years were the ones leading in simulation. For us, we were trying to be running around, send me suction tube, give me this, like that. So as we were managing the patients, we realized that the second year student who was performing the suction in an ICU, first of all, did not resuscitate the patient. The patient is supposed to receive 100% oxygen before you suction the patient, but she just went in and started suctioning the patient. Secondly, the method and how she was doing it, we did it like we've actually never suctioned any patient. And if this was a real live patient, we were going to kill the patient. We were going to push the circulation further into the lungs. But then it irritated the facilitator. One of them was not Uganda. She felt really so bad. If up to second year, this is what you can do to the patient. She was pissed off with us. Then later on, after when we were now getting the feedback, she expressed herself and she was able to overcome it. Then I said, okay, if this is what simulation can do, then every student has got to pass through simulation in order to provide quality care to patients in all areas, irrespective of the qualification of the student. Thank you so much.
Wow, thank you so much, Ms. Christine. I wish we could spend more time sharing this kind of stories because they are very, very powerful. But in the interest of time, we need to go to the next. So, Ms. Christine, starting with you, can you share with us any advice that you would give any teacher, faculty member who would like to start using this kind of training or simulation?
Okay, I would encourage all staff, all departments, and all institutions to adapt simulation as a teaching methodology. And the administrators of all our institutions to support the lecturers, the departments, when they show interest in simulation. Because simulation brings the scenario like a real life experience. Once you expose a learner or a student into a simulation setting, at that particular point, you see that you are really managing the real patient. And students take it upon themselves that I must really do it perfectly. And they are able to identify the areas of strength and the areas of weaknesses. Of recent, me and my colleague, we just designed something small. And we had a group of 5 students, we took them to emergency. And we were handling airway obstruction in children. So when we ran the simulation, it was not easy for us because we had not designed it properly, but we were able at least to do something with them. So we ran it, we actually did the first aid, we did the backflows for the babies with the children. After that, we got into giving the feedback. Students were able to clearly spell out what they could not bring up during the session. And I don't know what happened. After 2 days, they brought a 2-year-old, 2-month baby, an infant, to emergency. The child was eating a piece of meat, and the piece of meat got stuck into the airway. And it found 2 students were actually, out of the 5 students, 2 were rotating in emergency. And this baby was belonging to one of the students in the management sciences. So when the lady came and she was shouting all over, help me, my baby is dying. One student just grabbed the baby from the mother, not even taking it inside the room, turned the baby and gave a back blow. I was sent there personally, I was at the department. So the meat came out. When the meat came out, they had to keep the meat with them, and they called me, they called my colleagues, they said, come and see what has happened so far. They were so excited, they said, Madam, we don't want to go back to the skills lab. We want to continue to learn simulation and be in the words, but not being in the skills lab. Thank you.
Thank you, Ms. Christine. Dr. Data, what advice would you give to any faculty who would like to start this kind of training?
I'll give is that to start simulation needs determination and resilience. Because when you start introducing simulation methodologies, you're going to quickly find early adopters and late adopters, people who are going to resist the methodology because it takes a behavior change to start simulation methodology. Many of us were taught in a system where when you make a mistake, you are reviewed. How they provide you feedback is sometimes very different from how they provide you feedback in simulation. In medical school, we call it percussion. So they will ask you quite a lot of dirty questions and guess what I'm thinking questions. And they broke your mind. And so there is a mental change. My advice is that it takes determination and persistence. Once you get your early adopters, run with them, but don't forget the late adopters. Continue exposing them because they could potentially pull you down. The late adopter could be your dean. The late adopter could be your academic registrar. The late adopter could be your head of department. But in our situation, one thing has greatly helped. Very early on, we realized that it's very difficult to explain what simulation is. And the only thing that has helped us convert many people is when they ask us what simulation is, we invite them to the simulation lab. And by the time they arrive, before they know it, they are in a simulation session and they are managing a patient. And after the briefing, we tell them that is simulation. And then when you ask them, how can this be used for learning? They will tell you everything. So that method to me is the most powerful. If we are to start, let's get our decision makers into simulation sessions. And once they are in simulation sessions, they will understand the value of simulation and how simulation can be used for learning and teaching and for skills maintenance as well. Thank you.
Thank you, Dr. Data. I think that's a good way, rather than defining what simulation is, very difficult, right? It's very, very difficult to define. But seeing it really impacts on you, and you're able to remember what you learned. So 10 to 15 years from now, where do you see simulation being used or applied in health professional training?
So 10 to 15 years from now, what we intend is really to grow and consolidate the partnerships that we have started working on. So with the support of Elma Foundation, the International IDRC Canada, and the Leodol Foundation, and with the support of now SEED Global Health, we are working in partnership. First, working in partnership with Lira University, Uni University, the Catholic University of Health and Allied Sciences in Tanzania, and University of Jos in Nigeria. And our partnership is all around introduction and institutionalization of simulation in medical and nursing training. Now we think that with this kind of partnership, we would like to grow simulation to the extent that, one, medical students and nursing students, both graduate, postgraduate, certificate, and nurse and diploma, are exposed to simulation as part of their training, part of their teaching and learning methodology. Secondly, we have in the past designed simulation methodologies for simulation packages for frontline helpers for skills maintenance. So in 10 to 15 years, our dream, which we hope will get more people on board to believe in, is to partner to introduce and institutionalize simulation methodologies in medical and nursing training institutions, and also introduce and sustain simulation methodologies for skills maintenance for frontline health workers in Africa.
Thank you, Dr. Data. Ms. Christine, 15 years from now, where do you see this kind of learning being applied in health professional education?
Thank you so much. In 10 to 15 years, our hope is that we want to see simulation being practiced in all clinical and practical courses in our institution. And we also would like to have a fully fledged simulation center at Lira University so that we are able to train our professionals with a lot of skills and knowledge that will help them to actually provide quality care to patients. We would also like to incorporate simulation in the curriculum for both the nurses and the midwives, together with the curriculum for the medical students. And we hope to have better equipment within 10 to 15 years. And when we have better equipment and fully fledged simulation center, then we hope to have better performance in terms of grades of students and better performance in clinical area and patient's care as well. In 10 to 15 years, we would also like to collaborate with other educators and other institutions within the country and outside the country. At the moment, we are only collaborating with Umbarara University, who are really helping us to see that as Lira, we set the simulation center. And when we work closely with Umbarara University, we believe that in 10 to 15 years, we shall be the center of excellence in simulation in the region. Thank you so much.
Thank you, Christine. In other words, you want to take over from Umbarara University of Science and Technology. Dr. Data, you should be very afraid about that dream. Yes.
No, so that's a very, very dream.
Yeah.
A best teacher is one whose students become better than them. So I'll be absolutely happy.
We've talked about the good things about simulation. In your experience, what barriers have you run into while trying to teach students using this method of simulation? Ms. Christine, you can start with you.
Okay, thank you so much. Since we just began and we are yet a small step ahead, we have so many challenges as an institution, but we are trying to overcome the challenges with the help of Barara University. We still have few equipment, and actually most of them is still with Barara, but they will soon help us and then deliver them to us. So sometimes we enter into the skills lab for the 2 sessions we have run so far with my colleague. We've gone into the skills lab and we try to put things here and there. So, but we're able to perform a session, though it wasn't so easy because you feel that even the equipment you're using is not fully functioning. And we still have our simulation center not set. We actually still do not have a space. So sometimes we just move. The first one we were in emergency. The second one we went to maternity. The time mothers are not in labor suit is when we go there and say, okay, there's a space here. We can use this space to train these 3 students. So these are some of the barriers that we really have to bridge, though it's still not easy. We have shared it. We wrote a small report. We have shared with the faculty, and we are yet waiting for their response on this line. And as an institution, we like 4 of us trained, so we still very few on the ground. But we're also planning with our coordinator to have more trainings to other faculty members and to the students so that they get to see the real life situation in order for us to overcome these challenges. So, and as a team, we've had 2 meetings, and in the 2 meetings, we've already designed our way forward on the barriers that we already have. Thank you.
Thank you, Ms. Christine, for sharing with us the barriers that you've faced so far. Dr. Data, in your many years of experience, I'm sure you have like 1 or 2 barriers that you have faced as you try to implement simulation.
Barrier is in the people who believe that the current method of training, which is lecture, tutorials, and bedside teaching, are adequate, and that simulation is bringing additional workload. So people who think like that usually resist, and oftentimes I've had complaints that, this is additional work. Can we be paid additional money for running simulation sessions? And yet, the only sustainable way is to think of simulation as a methodology of teaching, just like a tutorial or a lecture or bedside teaching. But so getting people to accept that, as a lecturer, as a professor, simulation is just one methodology of teaching and learning that we should embrace. That's like we embrace tutorials and lectures is one challenge. The other challenge is usually related to egos. So you will pitch that, simulation will introduce reflective learning, and with reflective learning, students are going to learn better. And some people in management with egos will say, we have been a medical school or a nursing school for years and we have produced great people already. Why should we change? Why are you thinking we still need to change? So ego is another barrier. But that one melts. It's easy to melt when you put them in simulation. The third problem is usually related to institutional bureaucracy. Now, simulation sessions require that students have a dedicated time to go into simulation. And that means you have to slot in a dedicated time in the timetable for students to be in the simulation center. And once you start that, the common thing you will hear is, we have too much content already and we want to cut away some time for students to go to the simulation center. That is a challenge that has a bureaucracy too, because oftentimes you have to talk to the head of department, talk to the academic registrar, say, when we are releasing this timetable, is it possible to have a dedicated time for simulation at least 2 hours in a week or something like that? So there is that bureaucracy to navigate, and it depends on institutional leadership. Sometimes the bureaucracy is very easy to navigate. Sometimes there is a lot of resistance and a lot of block. The third issue is related to space, because a fully functional simulation center needs to be designed in a certain way for it to be easy. So when you introduce simulation and you have a class of 25, maybe 24 students, and you want to expose these students to simulation scenarios, for a class of 24, you at least need 2 scenario execution rooms and 2 debriefing rooms. And how we do it in Barara is that you will divide a class of 24 into 4 groups. So when the first group, 2 groups go in with their 2 facilitators, they do their scenario execution, and then they come out to the debriefing spaces, and then 2 other facilitators take the 2 groups, so that you are able to expose the entire class in small groups to simulation. And that requires space. That space needs to be carefully planned. And oftentimes, planning that space requires 1, the space, 2, a budget, and this budget take a process. That's one other challenge that is persistence and negotiation. And we are lucky that from Barata University, the university took it upon themselves. They funded the entire remodeling. They dedicated the space, funded the entire remodeling, hired a simulation coordinator. And then partners came in to support with capacity development. And it's that structure component that actually makes life a little bit easy for the early adopters. And so if that can be addressed, the early adopters find doing simulations easy, and then they can work on the later adopters to move into simulation methodology. So that piece is great.
Thank you for sharing those barriers. And I think it provides me some insight into some of the older institutions where everything is already in place, structures already built. I can see where that challenge can come in, but I think, as you mentioned, once we have early adopters, I think, and they really see the impact this kind of training can have on students and health professionals, I think they would be willing to take on the challenge and make those changes in the institution. So we've had a very good time sharing these experiences, your experiences with simulation. Just as we conclude, would you share with us any last words of wisdom? Anybody out there would like to start simulation? What words of wisdom would you leave them with? And Dr. Data, we can start with you.
So before I share my word of wisdom, I first want to thank our partners that have been able to help move the pin on simulation, especially in Africa. So, Elma Foundation, Theodore Foundation, IDRC Canada, and SID Global Health. You have been very great people in supporting the simulation agenda. Please continue supporting us. Secondly, I would like to thank the different institutional leaders, medical schools and nursing schools across Africa that we have reached out to, and they have opened doors to simulation, introduction, and institutionalization. So thank you so much, all of you. My last, you said word of wisdom. It may not be a word of wisdom, but I will say, don't struggle explaining what simulation is. Whoever asks what simulation is, organize and put them in a simulation scenario. Thank you.
Okay. Thank you. Those are great words of wisdom. Miss Christine, any words of wisdom, last words that you'd like the listeners to know?
Thank you so much. I would like to thank Malawi University for taking it upon themselves to see that they pull out the younger universities to also join the simulation. And I would also like to thank them because we now have a memorandum of understanding with them. And I would also like to thank SID Global Health for supporting us and for always actually checking in how far we've moved on with the simulation as a method of teaching. Especially I want to thank you, Irene, because you're so passionate about simulation. And we are grateful for that because it keeps us moving on. My advice to other educators, my thought is that if simulation would be incorporated in our curriculum for training health professionals, all categories of health professionals, it would be a very good thing to us as a country. And if we could all develop simulation setting with us and we incorporate other team members with us, this would really help us. I would also encourage all lecturers, all tutors to take it upon themselves. Those who have never had about simulation can just Google it on, read about it. My thought to other educators is that if we could take it upon ourselves during the development of curriculum for health professionals at all levels, we include simulation as a teaching methodology in our curriculum, and then we also incorporate it into the timetable or lecture schedule as per the institution. This could help us to train students, to train professionals who have got the courage, who have got the skill and knowledge that can help them transform the health sector and support the work of Ministry of Health. I would also encourage the administrators to support the staff and departments whenever they bring up issues concerning simulation. Thank you so much.
Thank you so much, Christine. I've really enjoyed sharing with you, Dr. Data and Miss Christine. You made me feel like wanting to go back to school and being a student, because I wasn't lucky to have that kind of training. Simulation by then was not yet. Nobody used even to talk about it. So I'm really grateful that you are spearheading this effort to change and improve our health professionals' education for nurses, doctors, and other health professionals. Thank you. I've had a good time. I hope the audience has also learned a few things on how simulation is going in Uganda, at Ubara University of Science and Technology, and Lira University. So thank you very much. God bless.
All right, thank you so much to our speakers so far this morning. And I want to say thank you to all of you for both your patience with the slight technology snafus, and also for your fantastic questions and engagement in the chat. So at this point, we are going to be taking a quick break just for 5 minutes to allow you to stretch, get some water, and then we'll rejoin. And while we're in the break, I'm just going to share with you our Twitter handles for today and hashtags, so that you have a chance to communicate with us through Twitter. And again, just encourage you to keep that conversation going through the chat box if you're interested in doing so during the break. So we'll be back in 5 minutes. Thank you all. Okay, welcome back, everyone. We are going to be transitioning to our next session, which is point of care ultrasound, educational and clinical applications. Give me just one moment. I will share the video.
A very warm welcome to everyone. We are very grateful to both the Consortium of Universities for Global Health and Seed Global Health for organizing this event. It's entitled Point of Care Ultrasound, Educational and Clinical Applications. My name is Basim Birkeland, and I am a physician based at the University of Zambia in Lusaka, Zambia. I will be your moderator today. I currently coordinate and teach in the Family Medicine Residency Training Program at a government hospital in Lusaka. We are utilizing point-of-care ultrasound on a daily basis on our teaching rounds using the butterfly ultrasound. I currently serve as country representative for Seed Global Health in Zambia as well. As many of you are aware, point-of-care ultrasound, and really ultrasound in general, is really starting to show its potential in this part of the world. We're realizing that with the short period of training, clinicians can learn how to perform scans that can have a significant impact on clinical care. With the emergence of portable handheld ultrasounds and the decreasing costs, we see tremendous potential in further integrating this modality into our educational programs. I'm privileged to be joined today by two panelists who use ultrasound not only in patient care, but in the educational setting as well. Our first panelist, Ms. Alma Anna Grace, is a lecturer at Inferior University, Faculty of Health Sciences in Uganda. She leads the clinical nursing and midwifery team at Lira University Hospital. She's a practicing midwife and sonographer. She has been in clinical practice for over 15 years, both in primary and tertiary healthcare settings. She is a very strong advocate for professional and safe workplaces for nurses and midwives, and she enjoys teaching and being in the educational setting. Our second panelist is Dr. Evaristo Cunca. Dr. Cunca is currently a third-year resident at the UNZA University of Zambia Family Medicine Program and part of the program's first class of trainees. He has played a pivotal role in the development of Family Medicine Program from its inception. Dr. Cunca graduated from the University of Zambia School of Medicine in 2003 and subsequently obtained a postgraduate diploma in epidemiology from the Tokyo Institute of Tuberculosis in 2010. He came to the University of Zambia Family Medicine program with a diverse portfolio of previous work experience, including working as a clinician from 2003 to 2019, when he finally joined the family medicine program. His professional interests include point-of-care ultrasound for patient care in Zambia, as well as point-of-care ultrasound education for Zambian clinicians and students. Currently, he is part of several studies evaluating the use of point-of-care ultrasound in the Zambian setting. A very warm welcome to you both. At this time, we will start our presentations, first from Ms. Anna, followed by Dr. Kunka, where they will share a little bit about their use of ultrasound and point-of-care ultrasound in the educational setting and highlight its clinical significance in their setting. Following the presentations, we'll have a discussion around this topic and have a chance to ask questions from our panelists. With that, Anna, can you please start us off?
Thank you so much, Dr. Basim, for the introduction. As he has introduced me, I'm Anna Grace Auma. I teach as a nurse at Mira University, Uganda. And I'm a practicing midwife. I'm going to discuss point-of-care ultrasound at not only Lira University, but say something about Ugandan perspective as well. I have been in ultrasound training and education and practiced ultrasound, but I would like to discuss a little bit about obstetric ultrasound today with you. Next slide. Okay, so Lira University is currently offering a Bachelor of Science in Midwifery program, and about to start a master's degree program in midwifery. As a bachelor degree program of midwifery is a 4-year program that prepares a midwife to be both a clinician, educator, and a researcher, and it enables them to practice independently. After that, within the curriculum of Bachelor of Science in Midwifery, there's a course unit inserted for ultrasound practice, but this is a very small part of ultrasound that is done within a period of about 2 weeks during the research term. This is, however, inadequate for practice to be proficient, but they still go through this anyway. My experience as a sonographer, I was privileged to be trained as a sonographer for a period of 1 year. The training was quite intense with more practical hands-on, and the mentors were really good. They were really able to mentor me with a lot of practical sessions. I practice general ultrasound, but more of obstetric ultrasound, practicing and teaching. And I teach the students of midwifery basic ultrasound in obstetrics. The students at the Lira University, however, have a basic ultrasound classes, especially in obstetrical ultrasound. And the students are very interested and eager to learn. But this is a very small time for them to learn what ultrasound is. I think because they have seen a little bit more benefit into having an ultrasound unit within your clinical area to enable clinical decision making when you need it in time. And if possible, if the student would have more time and a very portable machine, then they will be able to learn and then operate the machine and have more practical hands-on to aid in the operation. Obstetric ultrasound is a non-invasive, non-ionizing procedure that aids diagnosis in matters related to pregnancy, childbirth, and reproductive health. It is efficient in determining fetal and maternal well-being, diagnosing features of dangers to mother and the newborn and the unborn baby, and then it reduces turnover time for diagnosis. Bedside ultrasound in Uganda, however, has not picked up quite well. And we'll look at this challenge. How is this helpful in ultrasound? Obstetrical ultrasound bedside is helpful in the following areas. It is able to make a diagnosis of impending fetal distress and decide on how to prevent birth asphyxia. Birth asphyxia is when the baby is born in a very unable to, start the respiration and sustain, and therefore the baby is suffocated. In cases of cord around the baby's neck and decide on how to deliver the baby as fast as possible. Intrauterine growth retardation means the baby is generally malnourished intrauterine. Congenital anomalies that are life-threatening to the baby and make inappropriate decisions, whether to keep the baby or terminate the pregnancy. It is also used to diagnose position of the placenta in case of hemorrhage, which is a life-threatening obstetrical emergency. It is used in ultrasound-guided invasive procedures like amniotomy and taking off a blood sample from the fetus when you need to do them. Thank you. Important to teach in the clinical sectors, advocates, clinicians, and and to be equipped with the skills to make an appropriate and timely care decision. Ultrasound, point of care ultrasound is one of the modalities this kind of makes a life an intervention. Ultrasound, point of care ultrasound than other modalities like X-ray, because bedside ultrasound makes it easy to operate and therefore can be operated by a trained midwife, a nurse, or a doctor. It is cheap and affordable, especially in low-resource areas. It is non-invasive, portable, and safe, meaning that the patient does not have to worry about pain associated with the procedure. The images can be read in real time, and therefore diagnosis made easier and at the time it is needed. My experience as a sonographer and a clinician, one time I remember we received a Gravida 7 parent at about 13 weeks of gestation who walked in with severe abdominal pain, headache for 3 days, and she had been in a clinic before where she was being treated for acute appendicitis. When we encountered this lady, we made our evaluations. She seemed to be treated right, but something wasn't adding up. Decided to do a bedside ultrasound, just spot on. And then we discovered that she had an ectopic pregnancy where she had never learned that she was pregnant. So she had an leaking ectopic pregnancy that was impending rupture. She was then prepared for an emergency laparotomy, and she was made well after that. Some of the challenges and barriers to a point of care ultrasound in our setting. Training for nurses, midwives, and doctors on ultrasound imaging. because most of our curriculums do not include ultrasound as a course within their training. Not every emergency obstetric facility has an ultrasound scan unit, and therefore this makes it hard for the patients and the clinicians to access ultrasound imaging. Some facilities do not even have power to operate the ultrasound machines. And therefore, if we could have a small unit, portable, that you could use as cells that are rechargeable, therefore would make it easier to implement the point of care ultrasound. In conclusion, I would like to say that obstetric emergencies are life-threatening and not easy to make a diagnosis sometimes. But a point of care ultrasound makes it easy to save a baby who is getting suffocated, a mother who is likely to die from hemorrhagic shock and needs to locate the problem and arrest it, save a mother who is likely to die from ruptured uterus and so on. Therefore, I think that all clinicians, all clinical programs, training nurses, midwives, and doctors need to have an ultrasound training included within the curriculum to improve the diagnostic skills, especially in obstetrical ultrasound, for a quick and timely diagnosis and intervention. Thank you.
Thank you very much, Anna, for your presentation and for highlighting your experiences at Lira University as the clinical head of nursing and midwifery. And we really look forward to the discussion portion of this presentation, where we'll have a chance to ask you a little bit more about your experience. At this time, I'd like to reintroduce Dr. Evaristo Kunka, who's going to be sharing a little bit about his experience using ultrasound at the University of Zambia. Dr. Kunka, most welcome.
Okay, thank you very much to Dr. Basim for the warm welcome. And thank you very much, Anna, for the clear presentation on the use of ultrasound in maternity and labor ward. Let me take this moment to welcome everyone to this section of the presentation. I'll be talking about point of care ultrasound, more in internal medicine and pediatrics. However, that is not to say that we're not using ultrasound in maternity and labor. We are using point of care ultrasound in that area, but I think for the purpose of this presentation, I'll limit myself to internal medicine and pediatrics. Point of care ultrasound is a relatively new technology to us in Zambia, and it was incorporated in the new curriculum for family medicine, which is also in itself a new specialization in Zambia. So the family medicine at the School of Medicine, at the School of Public Health at the University of Zambia is the only family medicine program in the country, and it is a new program, and I was lucky to be part of the first cohort of students who joined the program. And having joined the program, I was again lucky to find that point of care ultrasound was part of the curriculum, and I think it is such an important component of the program. So point of care ultrasound curriculum emphasizes the identification of key pathological features to support diagnosis, monitor progress, and guide management of patients in our inpatient wards. So the point of care ultrasound has got so many benefits to both the patients and the physicians. With regard to patients, the benefits include the fact that usually there's no need to move the patient from the floor to the radiological department to have an ultrasound done. This can easily be done within the ward, just by the bedside. Secondly, patients who cannot afford a formal ultrasound can simply have a point of care scan done, and this can be used to make management decisions. Thirdly, echocardiogram can be done on the bedside. Usually, echocardiogram is one test that our patients have to go out of our facility to other facilities to have it done. But with the point of care ultrasound, we are able to do this just by the bedside and make sure that we pick up the key salient features of the disease condition to guide our management of the patient. There are times when the ultrasound machine within the facility is down, and at that point, the only alternative that we have for all our patients is the point of care ultrasound. For the physicians, some of the values of the point of care ultrasound include the fact that you can quickly have an ultrasound just by the bedside and make decisions, and then those can guide how you proceed in managing the patient. And I think for me as a physician, one thing that I've learned through my learning of ultrasound is that I'm better able to interpret reports that are done by other colleagues who are also doing ultrasound. Previously, it was a struggle, and I depended on the report that was provided. But now I'm able to kind of look at the image that has been provided and interpret it myself. So in terms of importance of ultrasound, point of care ultrasound, I think first and foremost, it is the fact that this is a non-invasive procedure, which is relatively easy to learn and perform. And once you acquire the machine, it becomes relatively cheaper for you to be able to do the ultrasound on your patients without probably adding any extra cost to the patient. The patients do not need to move from the ward or from the floor to the radiological department to have it done. So we not only save time, but we also reduce the risk in terms of disease transmission. For example, if we are looking at a patient who has COVID-19, having to move this patient from the ward to the radiological department will be exposing everyone that we are meeting along the way to the COVID-19 infection. It also minimizes the worsening of the patient's condition. For example, if the patient is on oxygen and then you need to kind of move them, you would probably need to kind of disturb the flow of oxygen, and that would put them at risk of worsening the condition, their own condition. It also allows for quick decision making on the bedside, and given the fact that in most of our rural areas, we have limitations in terms of imaging capacity. This kind of point of care ultrasound would prove to be very valuable, as it would be a non-invasive, cheaper way of having an imaging modality available at all times. As a registrar doing family medicine, I think that have benefited a lot from the use of point of care ultrasound. I've been able to make diagnosis on the bedside in a timely manner. I've been able to use ultrasound to monitor patients' conditions. For example, I would give an example of congestive cardiac failure or hypovolemic shock, where we can monitor whether we are over-diuresing our patients or we need to give our patients some fluids in case of hypovolemic shock, just by looking at the diameter of the inferior vena cava, where we see that the inferior vena cava is kind of dilated. That would guide us to say this patient is hypervolemic and requires that we diurese them. While on the other hand, where we find that the inferior vena cava is collapsing completely, that would point to the fact that this patient is dehydrated and requires that we give them more fluids. It has also improved my capacity to interpret ultrasound reports, as I earlier alluded to, because even when my colleagues have done ultrasounds from other places, when I get the report, I'm able to look at the images and I'm able to interpret what the image that has been provided is telling me. So now, during the days of COVID-19, I think point of care ultrasound has proved to be of great value to us as a facility. So in the early days, we didn't have diagnostics. And so point of care ultrasound was the only modality that we had to kind of make a diagnosis, or at least to have an idea that the patient that we had could have COVID-19. So patients with COVID-19, these are usually patients who have got low saturations, and therefore they're not easy to move. So even when you would love to do a chest x-ray in a patient with COVID-19, you're probably not going to move them to the radiological department because you're not sure of their condition, because usually these are people who are critical, and so you don't want to keep moving them around. And so the time, the diagnostic, the point of care ultrasound proved to be very helpful, because we were able to kind of do point of care ultrasound, and it was able to guide us. The type of findings in case of suspected COVID-19 would include diffuse B-lines, which could either be continuous or discontinuous. There could be subpleural consolidations. There could be air barograms, and usually the B-lines would be suggestive of an atypical pneumonia. And COVID-19, being a viral disease, usually will present bilateral diffuse B-lines on chest ultrasound. So these patients, once we found that their ultrasound findings were suggestive of COVID-19, we would make sure that we isolate them immediately and immediately set in the infection prevention measures so that we can avoid infecting the other people in the ward. And once the opportunity comes, when we have the ambulance available, we would refer the patients to a COVID-19 center for definitive diagnosis and further management. It was helpful in that it allowed the patients to have early access to appropriate care while minimizing unnecessary referrals, and also reduce the risk of disease transmission on the floor to the staff and other patients. So among the lessons that we have learned with the use of point of care ultrasound has been that it has been very well accepted in our facility by both our patients and colleagues. For example, other departments can now ask us to scan their patients when in need of an urgent scan. Secondly, patients who have been on waiting lists for cardiac scans can now have them done by the bedside or in the outpatient clinic, and decisions can be made there and then, either by the bedside or within the clinic. Then we are using the butterfly probe, which I think has got so many advantages. One, it is easy to carry around because it works by connecting to the phone, and you do not need to have different probes for you to be able to do different scans. You just need one scan, one probe that can change modes from lung to cardiac to abdominal, and you can also do small parts. So this particular probe, I think, has proved to be very good, especially in our setting where it's very difficult to kind of have different probes for different scans. Some of the challenges that we have faced has been that the number of probes that we have at the moment are few. However, we are seeing that the demand for scans is increasing. So we will be scanning in internal medicine. The labor ward could be asking that you go and scan a woman who is probably in labor, or a woman who has got PV bleeding. And so you find that if we had more if we had more probes, we'd probably be able to kind of meet the demand with much easy. The point of care ultrasound is a relatively new technology in Zambia, and so many may not be appreciated. It may not be appreciated by most of our colleagues who are in other facilities as a diagnostic tool. So as I conclude, I just wanted to kind of share some of the scans that we have done. So the scan that we are looking at now is of a patient who had come in with difficulty breathing and was saturating at less than 90. So what we are saying is that he's got B lines, and these B lines were actually diffused. And in this patient, we suspected that he could have had COVID-19. So this is another patient in whom we're suspecting that they could have COVID-19. Again, we see that he's got a subpleural consolidation, which is suggestive of COVID-19 as well. This is another scan for a young man aged 26 years old who had come in with a massive, with a history of difficulty breathing. And he also had chest pains. Upon doing the point of care ultrasound, we discovered that he had a massive pleural effusion. And just at the bedside, we were able to do ultrasound guided pericardial synthesis. And the patient felt much better just there and then. And so I feel like this is one of my best examples of how ultrasound has been able to help us in managing our patients. Thank you very much for your attention.
Thank you very much, Dr. Kunka, for your wonderful presentation on the use of point-of-care ultrasound in Zambia and in our setting. Once again, thanks so much to both of you for sharing your presentations. At this time, we'll open up the panel to any questions or comments or any discussion points. We'll just open it up to anyone who would like to share anything.
Great. Good morning, good afternoon, good evening to everyone around the world. Thank you, Dr. Johnson, for your help moderating this. Very, very informative presentation from Anna Grace and Dr. Evariste Kunka. We're so happy. We're going to take a few minutes for some question and answer. If you can just send your questions to everyone in the panel, we'd greatly appreciate it. Please talk, looks like Jan Nick has a question. Thank you for the live scans. I'm familiar with OB ultrasounds and teach my students about butterfly ultrasound probe using smartphones, but haven't seen other organs. Very interesting. Please talk about certification for the butterfly ultrasound. I think that among our panelists, I think Dr. Kunka, you've had the most experience with the butterfly. Can you talk a little bit about your experience learning how to use the butterfly ultrasound and doing butterfly ultrasound in general? Dr. Kunka, if you could just unmute your microphone. Let's see here. I think we're having some difficulty. Dr. Kunka, can you just unmute? There we go.
Yeah. Good morning, good afternoon, everyone. Yeah, so I think that the butterfly ultrasound, I think it has been a revelation to us as a program in Zambia. And I think this is because it is uniquely designed in such a way that you are able to kind of do different scans using one probe. Yeah, and the program that we're doing spans a period of 1 year. So the whole academic year, you're actually learning how to do ultrasound, and you go system by system. So you probably start with the heart, then move on to do the lungs, and then run through all the other systems like that. And so at the end of the day, when one has confidently learned how to do the ultrasound, then they can be certified as providers. Yeah, so I think that the program has come up with a certification system, and so far I think it is working well, and we hope that the people graduating from the program will go on to do this point of care ultrasound in their work. Yeah, thank you very much, Dr. Basim.
Thank you very much, Dr. Kunka. Let's see here if we have any other questions coming through. Please post your questions in the chat for everyone to see. While we're waiting for any other questions to come through, I think I'll just reach out to Anna Grace. Thanks again, Anna, for your presentation. For a quick question. So you talked a little bit about ultrasound in your setting. If technology was readily available to do more bedside portable ultrasounds, sort of how would that make a difference in your setting, sort of compared to what you currently use? Would you mind expanding on this a little bit, Anna? And if you could just unmute your microphone.
Challenges. Can you hear me?
Yes, we can hear you, Anna. Did you hear my question?
Yes, I did. Thank you, and thank you for joining us today. If opportunity to have a portable part of diagnostic challenges within these diagnostic challenges means we are likely to have a more timely intervention and reduce on the life-threatening conditions that usually compromise on the quality of life for both the mother and the baby. This point of care ultrasound, especially the butterfly, would be very helpful in settings like.
I'm sorry, Anna, we're having a little bit of trouble hearing you.
Because I want it easy to operate. It is
I'm having a little bit of
very
trouble
easy
hearing you,
available
Anna.
whenever you need to make a diagnosis. Try something else. Can you hear me now? What?
Yeah, I can hear you a little bit. It seems like you're going in and out.
What now? Can you hear me?
Yes, I can hear you.
Should be my network.
Thank you,
Okay.
Anna, for your response. Perhaps I might ask that you can. Sorry, Anna, continue, please. What I might suggest, Anna, given your connection, is maybe you can type your answer in the chat for everyone to hear, if you don't mind. If you don't mind, Anna, you can just put your response in the chat. That way it'll be sort of clearly heard by everyone. We definitely don't want to miss your comments due to a bad connection. It looks like we may have just a few more minutes while Anna is responding on the chat. Dr. Kunka, I just had another quick question for you. As with all technology, we sort of want to know about the cost and ongoing maintenance of a device similar to what you use, like the butterfly. Can you share a little bit about this in your context?
Okay. Thank you very much once again, Dr. Basim. Yeah, so I think that at the moment, the device that we're using is the butterfly. And I think for most of us, I think the cost is still on the higher side. Yeah, but I'm also aware that this is a relatively new technology, and it is expected that the cost could be slightly on the higher side. But our hope is that going forward, we probably would see that the prices begin to go down, and we could afford to get personal devices as either registrars or even as practicing physicians. Yeah, and in terms of the maintenance costs, I think that the butterfly in itself, from what I've observed, the 1+ years that we've been working with it, is that it's quite durable, and it should be able to kind of last for a reasonable long period of time. And so I think once one has a device, they should use it for quite some time before it would need repairing. Yeah, I know that sometimes you may have to pay an annual fee. Yeah, but I think that at the moment, with what we're working with, I think that there's been some support, and so it's been, yeah, at least we've been able to work with it quite well, and I wouldn't complain about how durable the device is. Yeah, thank you very much, Doc.
Great. Thanks so much, Dr. Kunkan. And I'm so sorry that we lost your connection. We definitely want to hear your response to the question as well. If you can just post the chat for everyone. Once again, thanks so much to our speakers, our panelists, as well as the organizers, Dr. Johnston, Seed Global Health, as well as CUGH 2021. And of course, to all of you for joining us here today.
Thank you, Dr. Berkland. So with that, we'll transition to the last session for this morning. And so I'm going to go ahead and share our last panel with you.
Morning, good afternoon. Welcome to this session as part of the satellite event for the CUGH. And on this session, we are doing a session on access, seeking equity in digital access to health education. With us today, we have two excellent panelists, Professor Adres Malata, Professor of Nursing from Malawi University of Science and Technology. Also have Ms. Roslyn Awili from Dignitas Limited in Kenya. And we'll have the opportunity to have a sneak peek in their experience in the recent past, one from the perspective of training institution in Southern Africa, and the other from the perspective of a practitioner in Kenya who's been deeply involved in community entry for new technology. So at this point, I will invite Professor Adres Malata to greet us.
Good morning, good afternoon. Thank you.
It's a pleasure to have you, Professor Malata. Ms. Roslyn Awili, do you want to greet our audience?
Sure. Hi, everyone. I'm super excited to be in this forum and to learn together with you all.
Thank you both for making time to share with us your experience this afternoon, morning for the rest of our audience. Thank you. So I'll pass this on to Professor Adres Malata. Like I mentioned, Professor Malata will share with us a little more about some of the challenges encountered around accessing digital education from the perspective of Malawi.
Thank you very much for having me once again. And I'll be talking about equity in digital health education, the case of Malawi, and I'm really coming from the perspective of higher education. My presentation, I'll look at the Malawi context briefly, really, and then about our university. I'll be focusing on key challenges in realigning learning content for effective online delivery, and of course, what measures we've taken here to mitigate these challenges. And about Malawi, Malawi is a very small country in southern part of Africa. We are called the warm heart of Africa, and you see in that slide beautiful people, beautiful animals. And also, you can actually see that we have a beautiful lake, Lake Malawi. About MUST, Malawi University of Science and Technology, we are the youngest university in Malawi, public university, but our focus is on science, technology, and innovation. We are offering programs in technology, engineering programs, for example, biomedical engineering. We have an academy for medical sciences, which is also, we also have a hospital on campus focusing on diagnostics. So medical imaging, medical microbiology, and our students have actually been very key now with COVID-19. And of course, we have a School of CUGH and Heritage, and certainly climate and earth sciences. Our university's mission, like any other university, we want to be a world-class center for science, technology, and innovation. Of course, research and entrepreneurship is also what we want to achieve. we want to provide a conducive environment for our students. And I think COVID-19 has actually challenged our mission, not only us as MAST, but also I think all other educational institutions in Malawi. And of course, we have core values, and innovativeness, commitment are some of our core values. I also want to share with the audience that today, as of yesterday, 23rd February, Malawi recorded 164 new cases of COVID-19. But you can see on that slide that we've had quite a number of cases that have recovered and those that are in hospital. The reason why I'm sharing this with you is that by 15th January this year, 2021, our record for new cases was over 1,000 per day. But as I speak now, numbers have dramatically reduced. And so we're hoping that things can get better. But one thing we know is that our lives will never be the same. And then, so what impact has COVID-19 have on the Malawian population? And I've grouped the issues in 5 areas. One, socioeconomic impacts, so poverty, gender-based violence, teenage pregnancies. We have seen those. By keeping students at home, many girls became pregnant. What about the healthcare system? COVID-19 has exposed issues of equity, access, and quality of healthcare, and of course, issues of mental health. And the focus of my presentation is on the educational system, access, equity, quality, issues of digital divide I'll be talking about, and of course, our students and staff support. But there are two positive issues that I've seen myself as a leader in higher education and also a medical personnel with a nursing background. We have seen that many of the African countries can actually innovate, because the way it is, all our countries have to depend on in-house, inbreed opportunities and of course innovations. And of course, we also have seen a lot of entrepreneurship opportunities with COVID-19. Now coming to key challenges, which is the focus of my presentation, I want to share that there are basically 4 issues that we have had to deal with. Lack of policy frameworks for online teaching and learning, lack of necessary infrastructure and also equipment, lack of experience. Pedagogy of online teaching is a big challenge for most academic members of staff, and of course, our students are not spared. They too have struggled. Now, moving on to policy frameworks, they are either poor or non-existent policy frameworks now, not only for Malawi, but for many African countries. And of course, for teaching and learning, they are using online platforms. And then, of course, lack of institutional funding for online teaching and learning. An issue of mine is the change on policies related to online teaching and learning and lack of poor accreditation, because accreditation is key for quality assurance of online teaching. Now, the issue of infrastructure, one of the issues that has really been a challenge for us here in Malawi, and I know in most African countries, is lack of adoption of robust online learning management systems, so softwares, platforms, and of course, poor network signals. So even if you want to teach nursing students, medical microbiology students, and they're in a poor setting, there's very low bandwidth there, and sometimes electricity access is a challenge, and of course, blackouts, and then lack of gadgets. How many of our students have got a gadget, a laptop, a tablet to use for online teaching and learning? Majority don't have. And of course, bandwidth is also very expensive. And coming to experience on online pedagogy, what we have seen is lack of knowledge and skills to deliver online teaching. And of course, how do you customize content for online teaching? How do you engage students? How do you properly assess students? And of course, the issue of perception and lack of equipment, even for the teachers to use when they facilitate online teaching and learning. And of course, lack of experience in active learning. How do you still ensure learner-centered learning when you don't see students, when students are somewhere 300 kilometers away from you? And then students, can they manage time? Because no one is chasing them to go into the classroom. That's another issue. Now, in terms of our students, they have poor perception, majority of them poor perception of online teaching. They don't have knowledge for online teaching. Most of them, when they were selected to go to university, they thought they would go in the university, sit in a classroom, and there will be a lecture in front of them. So they may not necessarily have those skills. And then, of course, use of other modes of teaching. So how do they use videos, how to use audios, and issues of engagement between lecturers and students, but also among students themselves, lack of knowledge and skills to deal with traditional forms of assessment, and of course, as I talked about earlier on, learner-centered approach, a huge challenge. And then, so what have we done to mitigate these challenges? First, I'll start with leadership. Engagement of public and private sector leadership. We need government support. Our ministries of education, of health, need to support digital education. So we've had to do that. And of course, private sector involvement. We have seen, particularly in my university, reaching out to private sector, to banks, to insurance companies, and they've been willing to give us even gadgets for students teaching and learning. Technology literacy, this is a huge issue. Even if people have PhDs, they may not necessarily know how to use technology. So this is something that we've had to deal with at leadership level. And of course, the use of online platforms and issues of quality assurance and making sure that there's also effective communication. Now, coming to academic members of staff, those staff members that teach health education programs, technology literacy. So as I said, it doesn't matter what educational background you have. Many people don't know what to do. We ourselves, including myself, has had to learn to use Zoom or Teams for meetings now. I was always used to going to meetings. Actually, I should have been a CUGH attending a meeting, actually attending in person. This has not worked because of COVID-19. So this is something that we all have to deal with. Of course, to also help our teachers know how to customize content, how to use some other ways of teaching, use of videos, PowerPoint, when your students are not there, course-based structuring, use of online assessment, and of course, tracking students' performance. And for our own students, technology literacy is something we've had to address, teaching our own students how to use this. And actually, we had to send out our faculty to students in rural areas and have sessions with them. Actually, we did this before COVID-19 hit first in our country. And so the second wave, we've already known what to do, and students also know what to do. And of course, issues of communication and helping our students know how to use assessment tools, how to collaborate with their teachers and fellow students, how they can also even source gadgets on their own, how they can reallocate whatever little they have to make sure that they learn. And so finally, what am I saying is COVID-19 has exposed equity and access issues to education and other social services globally. We know that. So Malawi, like many other low and medium income countries, even high income countries, have not been exempted. All of us have been hit by COVID-19. And educational systems, whether it's further education, any other educational system, has been affected. Yes, there are challenges, but we have had to take steps to mitigate these challenges. But I do believe, my last comment is that we should be willing as countries to invest in digital education. Donor agencies, governments, development partners, communities, we should all invest in digital education because our lives will never be the same. Thank you very much for listening.
Thank you so much, Professor Malata, for that compelling reflection. It's an interesting snapshot into what is happening in Malawi. At this point, allow me to transition to Ms. Roslyn Awili from Dignitas, Kenya, to share with us her perspective from lessons learned in Kenya around community entry for new technology. Thank you. Ms. Roslyn.
Thank you very much, Bonnie, and thank you, Professor Malata, for that insightful presentation. And just to add to what Professor Malata has shared, I could identify with most of the challenges presented, and bringing in the perspective of an educator's experience or point of entry to the community, particularly some of the lessons that we have learned for community involvement for any intervention measure, including, the digital education technologies in the communities. One of the key lessons we are learning is community involvement plays a key role in the success of any intervention measure that comes into play. So community involvement in terms of their contributions, their opinions taken into consideration from planning to implementation to follow up. And this builds the spirit of Ubuntu, the spirit of belonging and ownership of interventions designed as the communities feel involved and their voices heard. What you could say is equity of voice. And this also involves, co-creation, co-implementation as part of collaborative leadership. As an education organization at Dignitas, we believe that the community is better placed and with the right guidance and support to devise solutions to challenges that they are facing. So community involvement from the word go, from baselines to feedback sharing and that iteration process of getting learnings of any intervention enacted, be it digital or otherwise, using those learnings from the community in addition to data collected to influence the path, the program. So those would be my brief comments in addition to what Professor Malata has shared so far with us. Back to you, Bonnie.
Thank you so much, Ms. Rosie. Very compelling points that you raised right there. So I wanted to ask a couple of additional questions to further highlight a couple of other aspects around equity in access to digital education. You've both seen different attempts were made during COVID-19 to utilize digital education as a platform for rolling out access to education. We saw a number of schools, particularly in Malawi, roll out online learning, and shortly after starting it, they rolled it back because they realized that a number of people actually not able to access it because of hardware issues, software issues, electricity, and a couple of other pieces. Are there any lessons that you would share in terms of baseline learning or assessment to be done before you roll out education? Or are there any key aspects that you bring who are rolling out digital education pay attention to before starting?
Yeah, so thank you very much. That's a very interesting question. And I want to share, for me, this is a true story of what happened in our university and lessons I can share. So firstly, preparedness. And as I said, we started preparing in February 2020 when we had heard about COVID-19 and Malawi did not at that point even have a single case recorded. We decided to start looking for information about our students. So you need to find out what do your students have. We actually went out, we put up a survey, we checked who had a gadget, who didn't have a gadget. And so we had two models. One model we did as leadership of the university. The other model, student leadership, did it. And there was a discrepancy. So we recorded more needs than fellow students. So it means students were more open and truthful to their fellow leadership on who didn't have a laptop and who had a laptop. That was a good beginning, but what we knew when we were embarking on digital learning, teaching and learning, that so and so had an item to use, and these students do not have anything to use. So that is point number one. You need to find out what the students have, and then you can fill that gap. Point number two is preparing them on what to do. Because as I said, having a degree doesn't necessarily mean that you know how to use online teaching platform. And therefore, we have to prepare our teachers, we had to prepare our students. So there was actually sessions, teaching sessions, this is what we do. And we took our own tablets and gadgets that we had already sourced before COVID-19 to go out to the rural areas and teach them. And we also looked at issues of bandwidth. And then we knew that most of our students wouldn't afford. And then we proceeded to negotiating with companies in Malawi. So what must use us now is what is called reverse bidding. And so students don't pay, we pay. And but because we were the first to find that option with the telephone companies, when other investors were going, we were told, no, we were not making any money, so we can't do this for as many institutions. But what am I trying to say there? It means, therefore, that our governments need to lobby with these companies about costs, because bandwidth is very expensive. And I think for a rural student who doesn't even have resources to buy their own gadget, you don't even expect them to get bandwidth. So you have to look at infrastructure in terms of equipment, infrastructure in terms of bandwidth, who has what's available in that rural area, and the preparedness of the teachers. How do they do it? Because I went to do my PhD 10 years in Australia. The time I was going to Australia, I didn't even have a laptop. Today, people would laugh because they would think, no, you can't be doing your PhD without a laptop. So it means the world has changed, but at the same time, there's that digital divide where if you went into another country, everyone has a laptop. When you go to another country, particularly low and medium income countries, our students don't have a laptop. So there's each of equipment. And then, of course, I think leadership. There has to be that deliberate effort by our leadership to push for digital education and digital resources. So it's not just about us looking at who has what, but also there has to be that commitment on the part of your government to make sure that everyone, so at every level. So for me, what I see now moving forward, COVID-19 has taught us lessons that actually everybody needs a gadget. And particularly for our students, we're talking pre-primary, primary, secondary education, higher education, communities too. They don't have to be going to school to have a gadget, but with health education or health informatics, you can reach out to communities using, digital skills, but they will need to have a gadget. They will need to have a type of phone that can be used for perhaps if they need to get information or they need to get an alert, they need to get a prescription. So all those issues require an investment. So for me, another issue is, can there be investment? Can countries deliberately invest, not just looking at a donor to say UNICEF, USAID, UNFPA? No, even our own countries, part of the budget allocation should go towards, gadgets. And I speak now for needy students. Many of our students come from rural areas. They don't have anything. Can there be deliberate effort to ensure these students have got a gadget to use? Some bandwidth. No student should say, I was not able to download this content because I didn't have bandwidth. That bandwidth the universities pay, but it can only be done in some universities, because other universities, particularly big universities in Africa, are huge, and they have so many needs and so many requirements, so that may not necessarily be the case. But I'll ask my colleague from Kenya to also make comments. But for me, let's be prepared. We should never be taken again by surprise. And that's why now, even when we're opening schools, I'm fighting. Parents have written to say, no online teaching. I'm saying, no, we have to make it work. Because today's COVID-19, tomorrow it will be something else. But also you students enrolled. So it has many other advantages. It's not just about making sure students are not on campus. But I do think moving forward, no country, no institution should actually ignore digital education. We need it because it's a survival skill for our countries. But I think my sister can also share her thoughts. Thank you.
Thank you, Professor Malata. You make there is a very compelling call to action for institutions proactively work with government and other stakeholders and look some of those barriers for access to digital learning. Professor Malata, if I could ask an additional question in that regard, you did mention that government could be proactive in putting resources on the table, not just relying on external funding, and also proactively unlocking some of those barriers at a higher level. For instance, negotiating reverse billing agreements and other opportunities to subsidize access to digital education. Is there any key message that you convey for policy makers and government, other than that, in terms of making access to digital health open to everyone without social or economic discrimination?
Yes, so my message, perhaps my first message is private sector. Because private sector, most of these institutions do make profits. And I think there should be that push to private sector, even to have it as a requirement that they make a certain contribution to education, to health. And then of course, digital education could be one element where they can be that push. And as I said, in Malawi, we've seen how private sector has really waken up, even just making sure that there's provision for equipment for PPEs and all other equipment for our hospitals. And everybody is pushing in resources, which means it can be done. I think there's a one where you look to the east, to the west for help. Within our countries, there should be help. But also, secondly, I want to say that if there's a deliberate policy by a government to say for this budget this year, there should be this allocation to enhance digital education. In 5 years' time, our countries will not be the same. And also, policy to say every child have a computer, every child will have a desktop, whether or also want to say tablets. So if there's a policy that in your country, every child will have that, it will be phased approach. So you start maybe with higher education, secondary education, primary education. But I also want to encourage our countries to be innovative. Because for how long are we going to be ordering laptops? We should be able to make laptops in our countries. I'm not talking about parts, because I know people who claim we make laptops. When you ask where are the parts coming from, they're coming from all over the world. I do think that we have now grown as a continent and believe that we should be able to have our own people in our own countries. And I want to give an example. So one of the programs we're offering at MAST is a Biomedical Engineering. I saw innovations during COVID-19. They were even looking at working on ventilators, and I heard Kenya was doing the same. These university students working on ventilators, working on face shields, face masks that can be reused and washed. And so to me, the fact that countries in Africa were able to show these innovations is a sign that given an opportunity, the youth of Africa can actually innovate. And then if we encourage innovation, we'll find that instead of us looking at buying computers elsewhere, our own computers made in our own countries can actually be much cheaper. And then we can have a bigger spread rather than buying. I know when you're buying laptops from elsewhere, for 10 laptops, you'll be paying so much. But for the same amount, if you facilitate and encourage innovation and innovativeness and that creativeness, we may actually be able to make our own things in our countries and then have a better spread in terms of access. For me, access is always important. Equity is always important. Because at the end of the day, when everything is said and done, what will people say about our input in our own countries? And also, it's not always just about, can we look for help here? Can we also find help within ourselves? We are grown, and I do think that our countries now, and I would think that if I bought a laptop in Kenya, it should be cheaper than if I bought it in another Western country. So that's what we want to encourage. And also making sure that we can learn from each other. Yes, we can compete, but at the end of the day, I think we do better together as teams rather than maybe trying to be an island in one country. So that's what I thought I should say. But the key message is, countries invest, governments invest in digital education. Whether we like it or not, our lives will never be the same. Thank you.
Thank you, Professor Malata. What would be your call to action as we wrap up this segment, this Rosemary?
equipping them with competencies to ensure that they influence the teaching and learning practices of learners at school. And so we do this through the school leaders, who are either the head teachers, the deputies, and emerging teacher leaders at the schools. And most of the communities we serve are either public schools in the rural settings or what we call urban schools or community schools in urban informal settlements. And you would imagine that in these communities, they already have other factors that might hinder technological advancement or using technology as a learning platform. So pre-COVID, we would have face-to-face interactions, and then when COVID was here, we had to change strategy. We had to move our trainings and coaching to, over the phone or on different platforms. So one of the lessons actually that we learned, being that we work with school leaders who are, adult learners, is that adults want to learn. So adult learning principles came into play. But adults will learn if what they are learning is practical and applicable to their current situation. So we had to adapt our content to speak to their current needs. We tried to conduct surveys to find out what was really, what challenges were they really dealing with in the moment. We found out that trauma and anxiety was one of them, worrying about what will happen, will we have our jobs, will our schools be closed. And the platform that we use to collect this information, to communicate with our school leaders, first is we identified what is the basic technology platform known to our school leaders, known to these adult learners. And we leveraged on that technological platform. So leveraging on technological platforms that exist and moving from what is known to a learner to what is new and perhaps unknown to them, we have found to work. So, for example, we already had established WhatsApp groups for our school leaders to receive learning resources, to learn from each other. And so through those platforms, we were able to conduct training to address, trauma and anxiety, to share with them resources to ensure that learners were still learning at home, and partnerships came also into play to support this theme. So we looked around at who else has the same dreams, has the same, visions as Dignitas Education, as an education company. And so we found there was a lot of goodwill from the society, from organizations who were just willing to, donate funds for these teachers, to support them with teaching learning resources. And we were very innovative. I think previously we were waiting for, we had this strategic vision to move to, a digital learning management system. But with the advent of COVID, we found ourselves moving there faster because it was like, this is the season where you need technology as a plan. And so as we even supported school leaders from wherever they were, rural, urban, informal settlements, we employed or used what we called asset-based thinking and coaching. What did they have that was already working for them? Were they already communicating with each other, perhaps to help out on, social emotional well-being? Did they have any resources they are currently accessing, like learning via mobile? How do we use that to ensure they still can support their learners, even though the school environment has shifted from a forward institution to, homes? And that's brought in also the aspect of parental engagement. How do you engage parents now that the school has shifted from the school ground to the home ground, and understanding that parents are not necessarily trained teachers, but now they were wearing many hats. They were the teachers, they were the mentors, they were the friends, they were the parents as well. They still had to go out and fend for themselves. So understanding all these dynamics at play and addressing them, I think our baseline data provided that for us, so that as we were even implementing the program, it was speaking to the gaps identified, and it was impactful, I would say. And so we have also moved faster towards innovation. It's interesting what the human mind
can fathom when faced with a challenge. At first, you feel like this is impossible until it's possible, you know. And yeah, in as much as there are, you know, challenges that the COVID season has brought, I can say that we have leveraged on that to move as an organization. That said, I would also add that we have found value in existing partnerships with other like-minded institutions, other like-minded institutions and the government as well. So previously, these were existing relationships, but we were able to move that to the next level. It's interesting how you'll find that a challenge befalls the world and everyone, you know, becomes philanthropic, and the human spirit is just willing to reach out to each other and support and, you know, survive eventually. So we have benefited from being part of, for example, a regional education learning initiative that operates in East Africa. We've been able to share resources for learners, for educators, exchanging, you know, knowledge and being thought partners for each other on what strategies are working for us or for different teams, and borrowing ideas here and there. But also we have worked closely with the government on different fronts, pushing for policy changes in access and equity and coming up with frameworks that work, and especially for marginalized and underserved communities. So yes, partnerships have worked for us. Yes, we have been able to be more innovative, but also that has been made possible by the fact that we embraced community involvement, as I had shared before, in programming. And like I said, from planning, implementation to follow-up, in terms of co-creation, co-implementation. And so yes, there is still more that we can learn together, you know, as civil organizations, as learning institutions, as curriculum designers, as educators, as a health institution, and in the different arenas.
Thank you so much, Ms. Roslyn, for that very, very comprehensive reflection on lessons from Kenya. It's been an amazing learning opportunity. Sitting here as a moderator, I get the rare opportunity to sort of like be breathing in everything, the emotions and the celebrations. And it's good to see that in COVID, which was supposed to be a disaster, there was also a silver lining. And I had very powerful opportunities that came out of here, and best practices. And I think some of the key best practices I hear is innovate, invest, partner, leverage, co-create, and assess, not just dive in, assess, be mindful of the needs before you go in. And COVID being the push that we desperately needed to get us into the digital era has gotten us to test the waters, learn a lot of lessons that would set us up for success and equitable access to healthcare. Ladies and gentlemen, it's been an honor speaking with Professor Andres Malata from the warm heart of Africa as Malawian as they come, you know. And then from 254 as they go in Kenya, my very honorable neighbor is Awili, sharing with us perspectives from academia in Southern Africa, and then social entrepreneurship in Kenya. It's been such an honor speaking to you, ladies, and we look forward to reconnecting again in the live session at the Center for University Global Health Conference. Thank you.
Okay, thank you. Thank you so much.
Well, thank you, Dr. Isigwe and Professor Malata and Ms. Rosalind Awili of Dignitas. We're so pleased to have had you all join us. And I just want to finish out today with a few reflections on this amazing morning that we've shared together. You know, I think we started off with Mr. Leonard Wamakote encouraging us to think about pedagogy leading technology, and that we should see technology as a way of enhancing and expanding the impact of educators and of educational institutions. And Dr. Thomas Jerry Bali-Zakiwa has shared with us the power of students to lead and innovate in this area. We heard from Dr. Santorino Data and Ms. Christine Joya-Beja speaking about their experiences with overcoming resistance in being able to implement training and simulation. And they compelled us to think of determination and resilience as being key to implementing these new changes. Ms. Ana Grace Alma and Dr. Evaristo Kunka shared with us the powerful impact of simple and relatively comparably affordable technologies like point-of-care ultrasound in the clinical setting and as a method of enhancing physical exam education for students and learners. And finally, we finished with the opportunity to hear from Professor Malata and Ms. Rosalina Wheely, who encouraged us to think about equity of voice and thinking about doing adequate assessments and adequate surveying before we implement technology solutions to ensure equity in rollout and in access. So I want to thank all of you, all of our speakers for sharing these reflections, all of you who engaged with us today in conversations and questions in the chat and through Twitter. And I hope that you're able to leave this session with some ideas for how you might be able to implement changes or lead change in your own setting. So with that, we will wrap up here for today. But again, want to encourage you to keep this conversation going. If you have some further reflections and want to interact with all of us, you can through Twitter. I've listed our Twitter handles for those of us that are on Twitter here, including the corrected Twitter handle for Dr. Bali-Zakiwa. And I also received some questions through the chat about whether or not this recording would be available later. We will be messaging all of the attendees with information about how to access the slides and recordings at a later time. So don't worry, that information will be forthcoming. Finally, I just want to say thank you to all of you for your patience with our technological snafus today. Of course, as I mentioned earlier, it would not be a session on technology if there weren't some technology hiccups along the way. And hopefully we've shown you that you can move past them and overcome them. So thank you all so much again, and take care.